Good afternoon, everyone. Lisa Homa here. Hope you're having a great day. We're on to week lesson 2. This week's lesson is current issues in nursing. This is part 1 of 2. The objectives of this lecture, I am not reading them verbatim, I'm just going to hit the highlights. We're going to talk about the most prominent current issues impacting patient care in the U.S. We're going to talk about why there is such a push for a BSN degree and additional education. Talk about the importance of continuing education, and this comes from the IOM's report recommendations. And we're going to hit how current trends are impacting care at the bedside. We're going to start with Chapter 6. We're going to go over the quick and dirty about nursing theory. I will mention that Chapter 6 doesn't seem to go in a sequence based on the other topics that we're talking about today, but the reason I included this in your reading today is because this is to prepare for assignment 2. So I wanted to give you a little bit of an overview. So really quick about theory. All a theory is a word or phrase, a concept, bunch of concepts joined together in a sentence with an overall theme, and the whole plan is to explain, describe, or predict something. That is it. So who cares about theory? Let's apply this to something that you've already learned, okay? Remember, it predicts and describes something. So let's go to Florence Nightingale, what we learned in lesson 1. Environmental theory says, Florence observed that when soldiers were in an environment where the wards were clean, there was sunlight, the 10 domains that she included in her theory, that care and outcomes were better. We followed this same model taking care of patients in the hospital or even the home, right? We know that if those conditions are in place, the expectation is what we're predicting is that care and outcomes will be better. Okay, let's apply another theory and let's think about how this really works. Our program is underpinned with holistic comfort theory. In every single course, in Canvas, with the advising structure, all the different ways that the program is set up, it was designed for one thing. We know that when students are supported, that they learn better, they feel safer, and they will achieve the goals of the program. And that is the ultimate goal. Let's give one more really quick. Transcultural nursing theory by Madeline Leininger is a basis for nurses to make decisions and respect cultural and religious beliefs. Okay, I'm taking care of a patient who has a religious belief of Jehovah's Witness. Jehovah's Witness will not accept blood products. It's against their religion. But because I know this as a nurse, I can now advocate for that patient and I can support them in their decision and to help to encourage the provider team to find alternatives to the blood for them so that they can still follow their religious practices but yet still be cared for and their health is not in danger. See how theories work? In Chapter 8 of your text, so it's not even in one of your readings, there are multiple tables in there that give like a quick overview of all the different theories. Assignment 2, you're going to talk about at least one theory or a couple theories that actually underpin your practice. I'm not sure what that looks like, but just giving you some examples. There may be one that you find that you use. It's going to help you grow. One of the biggest things that I hope you get from Global Trends is really find out about yourself and what kind of nurse you are, because once you understand that, then you can see weaknesses, you can see your strengths, and it will really help you to cultivate and build goals and grow in your profession. Okay, on to Chapter 15. We're going to talk about the top 6 current trends in the U.S. They are all listed in terms of priority of what is the biggest and most important issue. It starts with healthcare costs, evidence-based care, nurse staffing, patient safety.
2 hours later.
Moral distress and burnout. Now that has happened from COVID, so I wanted to mention it. That's going to be a big thing you're going to see a lot of research about. So what this means is, so each person in the U.S. is given, it costs $11,000 per person to provide their health care to them. Yet, we are the most expensive healthcare in the entire world, and our outcomes is the second part of that bullet, the lowest life expectancy. We have equivalent patient care and outcomes as if we lived in a third world country. We have the highest suicide rates among 11 nations. So again, they're comparing nations that are similar to ours against what they call a benchmark. Is just comparing it against a suitable nation that is very similar to ours. Our healthcare costs are twice as much as the next nation who's next in line with us. That's how expensive, how much we pay for healthcare, yet our outcomes are terrible. We also have in the U.S. the highest chronic disease burden, meaning we have a population that continues to contributing to our overall healthcare costs. We have obesity problems, lots of obesity problems. We have a rate 2 times higher than similar benchmark nations. The one area that we are doing okay is we are outperforming our peers with preventative measures, such as breast care screening for cancer and things of that nature. We also have the highest number of hospitalizations from preventable cause and highest rate of avoidable deaths. So what this means is that we have a lot of work to do in our healthcare system to really bring things under control and to see better outcomes for our general population. All these measures that you're going to see that I'm listing now, all measures that we have implemented throughout the history from the 1900s to now to reduce overall healthcare costs. In World War II, we started with healthcare insurance, and that was a benefit provided from employers because what happened is patients couldn't afford to go to the hospital for care because at that time they cash paid for everything. All the services that they received, they paid a physician for that. And they realized that wasn't really a successful model because then people were refusing to go in for care because they knew they couldn't afford it. And then Medicare came in the early 80s. It really introduced a prospective payment system, a way of reimbursing hospitals. It was really the first measure implemented to try to contain the costs. Insurance companies offered a fixed fee to pay for hospital services, like a preset for any given diagnosis. Discharge, to give you an example, if I have open heart surgery, we're going to give every open heart surgery patient at discharge $100,000 to cover their surgery, anesthesia, and nursing care costs throughout the hospitalization. What they realized is priorities. We started from the top and worked our way to the bottom. All measures, when one didn't work or they didn't like the weaknesses that were associated with the model, they went to a different model. Health Maintenance Organization, they provided a strong incentive to avoid hospitalization and to decrease healthcare costs. Initially, it worked pretty beautifully. The problem with it is, like, let's go back to the open heart surgery patient that we were just talking about. More incentive for hospitals to get you out of the hospital quicker. Let's say hospitals were given 5 days for diagnosis of open heart surgery. If the patient got out and did pretty well and fast-tracked and got out at day 4, they were paid more money. There was an incentive to have you get out much quicker. Problem with that is it didn't help patients at all, and it ended up causing this boomerang effect where then patients then came back within a 30-day, the 30-day readmission rate was very, very high, and then that caused an increase or a surge in the cost to happen. So that wasn't all as successful as they wanted. Plus, HMOs don't provide a lot of flexibility or a lot of preferences for our patients and made patients really unhappy to go to doctors they didn't like or who were within the network. Out of that was developed the PPO system, where patients were allowed to now have an in-the-network and out-of-network option. It was HMO, but with a few more benefits. We still do see that until about 2010 when ACA stands for the Affordable Care Act, or Obamacare. And the whole purpose of Obamacare was to people in the U.S., they wanted to make sure that everyone had health care coverage, and they thought that this would minimize the out-of-pocket costs. So what happens if you have the homeless guy who gets hit by a car and then has surgery in the ICU, is in there for 3 months with the admission, and he has no insurance? Who pays for that? We as consumers, we pay for that. Obamacare was a great concept because now everyone had insurance and it would reduce that overall hit of getting somebody like the trauma patient with no insurance. It worked initially. We realized that now healthcare spending is now going up again. Worked initially, but now we're seeing, again, not so good things coming from Obamacare. So now they're moving on to the focused healthcare spending reductions. The thought in this is, what are the 4 top areas that if we could reduce all 4 of them overall, it would probably provide us with the greatest impact of reduction overall in total costs? Enlisted in terms of priority, hospital care is at 32%, so we spend most of our money there. Physician services, 20%. Dental, professional, home health, medical equipment, products, and public health activities equates to 20% of the overall budget for healthcare, and prescription drugs is at 10%. So you'll notice that there's a lot of areas we're focusing in those areas that maybe not before, but since 2010, we certainly are. Value-based purchasing, I wanted to mention this. I came from the University of Pennsylvania Health System, and they actually use this model. So there's two types, but the one that Penn is utilizing, let me try to connect this to why it's important for you going back for a BSN and why having an education that provides you with evidence-based knowledge is so important. The way the other payer models work is that if a patient develops, let's say, a urinary infection, for example, they are not reimbursed for that hospital stay. So let's say that patient went in for knee surgery, now ended up with a UTI, which is a complication. Let's say it costs $10,000 to treat that complication. The hospital will no longer be reimbursed for the extra $10,000. They'll only be reimbursed for the surgery, but no additional things. They have to eat that because they did not produce a good outcome. What a value-based purchasing model says is that you get incentive for beating the benchmark. So what that means is every hospital, no matter where you are, acute care center, is compared to other hospitals that have a similar structure as they do. So Penn said, well, we know we have better care and outcomes than most places. We hire nurses that we are 100% sure are going to utilize evidence-based interventions to support their patient care. So we know if we have that in place that 100% we're going to beat our benchmark and we're going to get incentive pay for those great outcomes. And that's exactly what they did, and they're killing it in that area. They're doing really, really well. The reason I mentioned is, one, is that means the drive for education is going to be really super important. And two, you're going to see that other hospitals are going to switch to this. So if they're not focused on it now, they certainly will have to be, because it's going to be one of the only ways that hospitals are going to stay afloat with the increasing healthcare costs. And so let's talk about care coordination, which is just really quick. How many of you, if you are working in acute care, deal with social workers, case managers? Do you think that a hospital did that just because they wanted to ease the workload of a nurse? No, they did not. Let me just let you in on it. Hospitals do things because they have to, because of finance. Care coordinators save hospitals money. It targets the care. It connects patients to other healthcare disciplines if they need it, like physical therapy person or whatever. And they know the most efficient way, and by utilizing their services, they can maximize the reimbursement that hospitals get by using them. Another healthcare reduction measure are nurse navigators. Nurse navigators are focused on dealing with chronic disease management. That's what they are. If we utilize nurse navigators, they help us to keep our chronic disease people from having to be readmitted constantly. And now, continuing on with that same topic with disease management, there's a huge focus now on multidisciplinary management to improve the quality of cost of care for patients with chronic conditions. So maybe some of these you are using, or maybe you're not, or maybe they sound familiar. Have you ever heard of a clinical pathway? Clinical pathway guides our nursing care so that, hey, if on day 2 the patient's Foley wasn't taken out, it's going to prompt us to say, Dr. X, Y, and Z, or provider, could you please tell us, I think the patient Foley catheter can come out today. Focuses our nursing care on being more efficient, and if we follow the pathways, we get our patients out of the hospital quicker. Therefore, hospitals are reimbursed at a much higher rate. You also may notice, I'm not sure if they do, that hospitals are utilizing things such as Elsevier has a resource for nurses now. It's called Clinical Key. It's where you can type in protocols and, hey, if I'm doing an arterial line dressing today, what kind of dressing is the most evidence-based? That is also a disease management. It's also a form of a clinical pathway to reduce overall costs. Let's talk about shortages of nurses, and this is a really tough one. So the ANA projects that there will be more RN jobs available through 2022 than any other profession in the U.S. The BLS stands for the U.S. Bureau of Labor Statistics predicts that 1.1 million additional nurses will be needed to avoid a further shortage. Employment opportunities are going to surge for nurses at 15% above all other occupations from 2016 to 2026. You are going to be a hot commodity, and they are really going to need you. So the shortage is going to continue for the foreseeable future. That's what they're saying in the research. The other thing we're noticing is, why put us through all this stuff to get nurses through nursing school? They graduate, they get a job, and guess what they do? Then they quit. Retention is critical. Employers are now focusing their efforts at creating compensation packages for nurses. They're working on a culture of training that includes mentoring, constructive positive feedback, and a recognition for excellence. In addition to this, there's also a push, and we'll get into that in just a second with the IOM, for residency programs. The cost on average in the U.S., I think it was in 2018, per nurse for onboarding and orientation when you start a new job somewhere is $57,000. It's higher in urban areas. So like in the city, it's up to as high as $74,000. So if you quit before the end of orientation or within that first year of working at an institution, they lost that money. They're not going to recoup that money. So magnet status, you may not like it or you may like it, but the bottom line with it, in order for hospitals to get reaccredited with magnet status, they have to maintain a favorable nursing, and it's called an NDNQI survey. It's basically overall a satisfaction survey for nurses. And if it's not favorable, Hospitals don't get recertified on their magnets. So if you want better working conditions, it's more likely that you'll find them as a nurse in a magnet institution. So the Future of Nursing report in 2010 shows that they prioritize of healthcare, primary care shortages, so there aren't enough doctors either, the aging and sicker population, healthcare disparities. I hope you know what that means. That means any person, two people coming in with the same condition, let's say two people with COPD, if one has a different color skin, their care and their outcomes may not be the same. And that's what we're noticing. And then fragmentation of care, which I'm going to go into a little bit of detail with you in one of the next slides. Essentially, the IOM brought together multidisciplinary groups, and they developed this overall strategic plan for the healthcare system. And really what they're speaking about are nurses is they want nurses to practice at the full extent of their education and training. They want a seamless academic progression, so that's what we've been trying to work on in our new program. Nurses should be full partners with the other healthcare disciplines, and we're seeing much improvement in those areas. There should be effective workforce planning. They want to remove the scope and practice barriers and expand opportunities for nurses and to lead specifically in areas of improvement efforts. They want nurse residency programs. And then, of course, we talked in lesson 1 about the BSN. They want 80% of all nurses working to be BSN prepared. They would like people with the number of nurses with doctorates to double by 2020. And they would like us to lead change along with the other disciplines to be part of restructuring the healthcare system, since we are the most prevalent profession of all the disciplines in healthcare. Nurses,
this concludes
there's the
part
most
1.
amount of
Stay
us.
tuned for 2.